Welcome, everyone, to the second installment of the Kennedy Forum's 2021 Virtual Spotlight Series, shining a light on mental health and substance use disorders. I'm Peter O'Brien, Chairman of the Kennedy Forum, Illinois. I proudly represent my fellow board members, and together, we're honored to join former Congressman Patrick Kennedy to eradicate the stigma associated with mental health and substance use disorders, and to create equitable access to care and support. 15 months ago, we were thrust into a new way of being that included isolation, threat of sickness, and fear for the unknown of what was to come. COVID-19 was ravaging the world, devastating economies, and taking so many precious loved ones away from us. In our homes, we struggled and continue to struggle today. We struggle with grief and depression. We struggle with anxiety for the future, and some struggle with increased substance use to dull the pain. But also, 15 months ago, 14 chief executives of the nation's premier mental health and substance use disorder organizations came together in unprecedented unity to develop a roadmap for advancing care. These leaders knew that COVID-19 would only compound the systemic challenges in care that existed before the pandemic, and now was the time to act. In December 2020, these 14 executives released the United Vision for Transforming Mental Health and Substance Use Care. And in February of this year, 35 additional national organizations joined on to support this vision. You can access the document through the link in the chat box. Today, the Kennedy Forum is bringing together 3 of those 14 leaders, including our founder, former Congressman Patrick Kennedy. I want to thank Patrick, the board members, and the staff of the Kennedy Forum, Illinois, for their leadership in producing these events. I also want to thank all of the sponsors who made this program happen. Your financial support is essential to our work. We could not do it without you. And finally, I want to thank you, our participants, for being committed to this mission. I hope that you find this program enlightening and motivating. I ask you to click the button in the top right of your screen and make a tax-deductible donation so that we can continue this important series. Despite today's conversation and ask questions of our panel, I invite you to think more critically about how you can contribute to the way forward in mental health and substance use care. And now, I'm honored to introduce my dear friend and the reason we can all be here today, former Congressman Patrick Kennedy.
Thank you so much, Peter O'Brien, and to all my friends at Kennedy Forum, Illinois. I just want to thank you so much and congratulate you on the incredible work that you're doing, putting Illinois on the map and leading the way in the country in terms of state-sponsored oversight of the Mental Health Parity and Addiction Equity Act, the recent Jim Ramstad bill named for my late colleague, my good friend and my Republican co-sponsor, such that we could implement a lot of what we've learned from the decision on the WIT versus United on how we can better implement parity through better oversight of medical management maneuvers and ways that, unfortunately, many payers still try to circumvent coverage by imposing much higher treatment and thresholds or not allow for adequate networks to provide the care and then force people out of network to pay more out of pocket than they would if it were any other physical illness. I also want to thank you for your leadership on coordinated specialty care for schizophrenia and psychosis. Kennedy Forum, Illinois led the way in Springfield on that as well. You've really got a powerful team up in Springfield, and you're really showing how active a state can be in really advancing mental health. In the city, you've trained so many first responders. You've done the lunch and learn. You've done the workplace mental health. You're all over it out there. And I just want to thank you for the model you're setting, Peter. If it weren't for you, frankly, I would not be able to have served on the President's Commission on the opioid crisis and really translate a lot of your work onto the national stage, or currently as co-chair with Josh Gordon, the head of NIMH, for the national response to COVID, particularly around suicide prevention, or in light of today's discussion, being a member of the prestigious group, the CEO Huddle, which is made up of all the kind of principal leaders within the mental health advocacy. I think all of us came together because we knew we needed to do a better job at outlining the mission and really writing the roadmap for what would help improve conditions in this country. We started with parity, but as you know, there's so many additional things. Over the last several years, we focused on education, we focused on criminal justice reform, we've focused on the workforce gap. We've really covered the waterfront in so many ways, and so many of you on this webinar have been part of contributing to that effort. And I certainly look forward to getting back in person with all of you to keep driving it forward. As you said, Peter, no one could have imagined how COVID actually would have been our mental health moment. We were looking for a reason to get this conversation to a broader audience, and COVID really, if there's a silver lining at all, it's the fact that people are talking about mental health in ways they never did before. So we can't miss our opportunity. And thanks to all the good work that you've done, we can now take all of our lessons learned and implement them into public policy, because policymakers are looking for these solutions. So to that end, I want to thank my great friends, Paul Gianfredo, who's stepping down after many years of running Mental Health America, the nation's leading champion for parity. Early on, we had Mental Health America hearings all across the country on parity. And Paul has been such a champion on before stage 4, which is moving upstream and obviously addressing these issues principally by reaching out to young people and really implementing science-driven solutions for early intervention. How prescient you've been, Paul, with your leadership in there. And we have Dan Gillison, who's the new CEO of NAMI, the nation's leading advocacy group for people with mental illness. And I want to thank him for not only his work at NAMI, but for leading this unified vision document. And really, I wish I could say, and I think we all wish we could say, that we did this out of some, big picture vision of the need for us to all work together. I think we've always known that we needed to work together and join together, much like our friends in labor have an AFL-CIO, or the Chamber of Commerce has a Chamber of Commerce, or environmentalists have the League of Conservation Voters. But in mental health, we've often been siloed by our diagnoses. And really, we've failed to really see our common interest in banding together with all the facets of mental health. And yet this CEO Huddle really, I think, did a great job in coming together and articulating a combined agenda that can unify advocacy, which, as you know, is so crucial to getting the policy changes we need. So I know both of them are going to really dive into the 7-point plan, go through, the early intervention, crisis management, parity, quality standards, workforce issues, and really the moment also upon us, and that is the racial reckoning in this country, and how we need to make sure our mental health system is responsive to all communities in this country, and to make sure that our system is culturally competent and really meets the needs of those who've been impacted by the racial pandemic, along with the COVID pandemic. So with all of that said, again, thank you everybody for participating. And now I turn it over to our fearless leader, Cheryl Potts, who's doing a terrific job keeping everything rolling out there. And I'm sorry, I've already probably overstayed my time. So thank you, Cheryl. I think you're on mute. The famous word of this crisis.
Yes.
Now, I think. So, of course, leave it to me, the one who's been taking care of all the technical details all day, to mess it up. So, Patrick, you never have to apologize for taking too much time. We would always give you as much time as you want, because your vision and your words are so inspiring and motivating to all of us. Just thank you so much. And thank you for bringing us all together today. As our opening video highlighted, and both Peter and Patrick noted in their statements, our world has been living through a shared trauma with the COVID pandemic. For over a year, we have been thrust into grief and isolation and fear for our health and the health of others. And all of this occurred in a country where mental health and substance use treatment services are already woefully inadequate to address the current need. So I'm thankful to have visionary leaders such as Patrick and Dan and Paul on this call who have helped develop a roadmap for improvement. This roadmap outlines goals and pathways for achieving success across the 7 domains that Patrick just mentioned: early identification and prevention, emergency and crisis response, equity, integration, parity, standards of care, and workforce development. Joining me to discuss these critical issues are 2 of the original authors of the Unified Plan: Dan Gillison, the CEO of the National Alliance on Mental Illness, and Paul Gianfrido, the CEO of Mental Health America. Their full bios are located in the lower half of the screen. We encourage you to utilize the chat function on the right side of your screen to participate in the conversation and also to get links to important resources. We will also take questions at the end of the discussion, and I encourage you to submit your questions through the QA function. So let's jump right into it. Dan and Paul, this past year also, as Patrick mentioned, highlighted extreme racial inequities in our country. We saw the murders of George Floyd and Breonna Taylor and so many other Black individuals at the hands of police. And we also know that Black and Brown communities are disproportionately impacted by COVID. A significant tenet of the Unified Vision focuses on equity. Can you talk about what some of the pathways to success for this would be? And I'm going to start with you, Dan.
Yeah, thank you, Cheryl, and thank you for the opportunity to participate on today. Let me just start out by saying this is about leadership, vision, and execution. So I'm here with 2 incredible leaders, Patrick and Paul, and really do appreciate that and wanted to acknowledge NAMI Illinois, NAMI Chicago, and their leadership team, the staff, and volunteers. Now, getting into the question about equity, yes, last year was a reckoning. It created so much fear, uncertainty, and doubt. And inside of the Unified Vision, we talk about equity, and we have several different pathways that we address there. The first one is including the race, ethnicity, and language data, making sure that there is a comprehensive collection of that data in terms of, and for mental health and substance use disorder with respect to people served, providers, and outcomes. The next one is developing screening for caregivers and treatment programs that are responsive and have humility about culture, race. And the big part of this is Patrick and I were on in a session with Dr. David Satcher on the 1-year anniversary of George Floyd's passing. Dr. Satcher talked about cultural humility. So this training needs to include training on cultural humility. And this training would be to reduce the disparities, including racist and anti-discrimination training. And then the other one, and the last one I'll mention because there's about 9, is addressing adverse childhood experiences. Very often in communities of color, what happens is that you address the symptoms and you don't get to the root cause because you haven't peeled the onion back and you don't understand that there's been trauma. And if you understand those adverse childhood experiences, that really does help in your assessment of the situation. And it helps with the social determinants of health in terms of the rationale and what is happening with that individual. So that's a part of the equity lens that we're looking at it through with the Unified Vision.
How about you, Paul? What recommendations do you have that we can take forward from the Unified Vision with regards to racial equity?
I think that we need to make certain, first of all, that we have given everybody access to care, services, and support. I think one of the myths that's out there is that certain people in certain racial and ethnic groups are far less likely to take advantage of mental health services and supports. And the myth is because there is more stigma, or because they're told not to, or because of this kind of paternalistic references or issues within the society, within the culture. And I think the fact is, and what we're learning increasingly, is that it's not because of any of those things. It's because of choices that have been made by other people to deny access over extended periods of time to culturally aware, culturally competent, community-based services and supports that are use the same language of people and use the same experiences of people and help people who are peers of those folks to show people and guide people along pathways to recovery. I think one of the things that Unified Vision does, and one of the things we can pull out of that, is this conceptual framework that we have to act from, an understanding of what people themselves are going through, and then what they tell us they want and need. Not what advocates like me think they want and need, not what existing service providers want to offer to them, not just in the locations that we've historically provided services because we say, that's the best place for these services to be, even though we know that there is an access. And of course, in coverage as well, in identification as well, we have to eliminate the lack of coverage for the only services that sometimes people find available, like emergency room coverage. We were talking just before this show about that. And similarly, I think we have to, both cease the over-identification of some people, particularly Black males, for certain things, while under-identifying, populations of color in general for the kinds of services that many people who aren't of color simply take for granted.
I thank you for that. I want to follow up on something you said, Paul, but actually hand it to you, Dan, because for years, NAMI has operated a helpline and a crisis text line. So I think you have a really great and informed perspective on our country's crisis response. And Paul really brought that to bear as far as an area where we really need to focus on fixing. So where do you think the gaps are in our system, and what do we need to do to strengthen our crisis response for mental health?
Yeah, thank you. I think the first place, and our helpline has been in place for over 20 years, and we did see a 65% increase in outreach through 2020. So that's first and foremost. And two of the top areas of outreach looking for resources have been with anxiety and depression. With that said, one of the other elements that we're seeing is the need for a different response to a person that's having a mental health crisis. And we know that in July of 2022, there will be a new number that will be for to be in place of the National Suicide Prevention 10-digit number that no one can remember, and also for for mental health crisis, and it'll be 988. And that number will go live in, it is not live now. From the standpoint of operationalizing it, it will go live in July of next year. What that will help with is a different type of response. Now, with that said, that's just a number. That's not the panacea. What we need to see is infrastructure built out on the front end. That's why we have workforce included in our 7 elements, critical elements of the Unified Vision. And then we need to say that you have a mobile crisis unit, and you now have the workforce where you have a triage model and you have its staff. Where does that staff take the person that they pick up? So we've got to work on solutions on the front end and infrastructure on the back end. But one of those that we're looking at for crisis response will be 988. Now, what that means to this audience here is we need you to be asking in your communities and your legislators about 988, because we also need it funded. So that's another piece here in terms of user fees from the telecom industry to actually support operationalizing 988 and making it pervasive across the United States. But we've seen across this country the response when law enforcement, who doesn't want to be the responder, to these type of crisis, and it ends up being the wrong response. So 988, we hope, will help with that with the mobile crisis response.
Great, thank you. Switching gears a little bit, Paul, the Mental Health America just last week published a report analyzing survey data that you collected from January through December of 2020, showing areas of high reports of suicidal ideation, including very high rates in my home of Cook County, Illinois. How can data such as this data that you collected inform efforts around early intervention and prevention so that we can prevent people from needing a crisis response?
Well, I'm glad you've asked that, and you reference it as, you know, the data and survey data. And I think a lot of people, when they think about that, think of some kind of, you know, randomized group of people or some kind of selected body of individuals that are interviewed and talked to in order to, you know, for somebody like me to figure out what it is they want. In fact, where these data come from are our online mental health screening program. Any help seeker can access this online program and take any one of 10 evidence-based mental health screens. And 15,000 people every single day access this. So as a help-seeking population, it's just a bigger group than anybody else sees. And it's a bigger group than get through to our warm lines that our affiliates run at Mental Health America. It's a bigger group, I think, probably that gets through to Dan's phone lines, bigger groups than get through to you know, the crisis text services, the suicide prevention, all of those. And in each of these groups, I think, help to inform us about what it is people need and what it is we can do for them. So all of these sources of information are extraordinarily valuable to us. And in this instance, the 15,000 people who come every single day, 2.5 million last year, will be closer to 4 million this year, maybe 5 million by the time we're through, are telling us a lot about what help seekers want and need. And what they tell us they want and need are more information. They want and need do-it-yourself tools, engagement with peers, and then referrals to services and supports. Those 4 things. And not everybody wants all of those things. So what's happened in the past, and I'm sorry for this answer being a bit long, but I think the context is important. What's happened in the past is when clinicians have done screening or widespread screening has been proposed, and the U.S. Preventive Services Task Force has recommended regular mental health screening for everybody over the age of 11. It's reimbursable by insurance companies and all of that, but few of us get it. It's because they think only in one box. If I screen somebody and they have a need, I've got to refer them to a specialist for treatment. Not everybody wants and needs a specialist for treatment. As I mentioned, some want peer engagement, some just need more information, and some even want do-it-yourself tools. What this information provides, when you look at a help-seeking population that has not yet been diagnosed for the most part, they tell us what it is they need, and then we can build a system of care services and supports around their needs. And what our report did last week was actually reduce this with 750,000 of them to the county level so that you could see what's going on in Cook County. And other people, even in small counties in Kentucky and Indiana, for example, could see that they were having excess suicidal ideation among help seekers as well. Now we have the opportunity, as a result, to intervene far earlier than we've ever intervened before. We can use this information about what people are telling us in our community so that we don't have to listen or just listen to Dan and me. I mean, we wish people would listen to us and do all of the things in the unified vision. But we know people are going to pick and choose those things that work best for them or make most sense for them at a local level. Well, now you can pick and choose based on what the people in your local area are telling you they want and need. And you can, and with using our information, because there's so much of it, you can break that down by age, you can break that down by race, ethnicity, and you can break it down by location. So you can do a lot of work to make sure that your interventions are precisely targeted to the people in your community.
Thank you. And you gave some great examples of some broad categories of services, such as referral to services and so forth. Can you give some specific examples of what some of the successful early intervention and prevention efforts are that communities should be thinking about adopting if they don't have those already?
And you asking me that?
Yeah, I'm sorry.
Again? Okay.
Yes, I'm asking you.
Sorry. Yeah. I'll tell you. You know, my favorite, honestly, is that we really should be reevaluating everything going on in the schools. That the best schools are identifying kids' mental health needs right now as they return to school, and they're making them eligible for special education services based on their mental health needs, if and when they need them, because the mental health needs they have are impacting their educational success. This gets us to data everybody knows. You know, half of mental illness is beginning by the age of 14, and in the help-seeking population, 40% of the people using that screen. So 40% of 15,000 people a day, 6,000 people a day between the ages of 11 and 17. Never been diagnosed before, not getting any treatment currently for the most part. So we've got to go to the schools and we've got to provide broad-based mental health supports for every child returning back to school. And the most successful communities are focusing most deeply, I think, on kids in schools and making certain that kids in schools get the support they need to stay in school and to succeed academically and educationally.
Great, thank you so much. Dan, Patrick has said many times in the past that the brain is part of the body, and all of us on this panel fundamentally know that to be true. So why is it that mental health, substance use, and medical health care are all so siloed? And I guess, you know, more importantly, to the authors of the Unified Plan, why is it important that we increase integration of care?
Yeah, the integration of care, first, it goes back to what Paul was saying about systems of care. You know, if you do what you've always done, you'll get what you've always got. And where we are right now is we've got to transform our health system to be inclusive of mental health. We have separated, and one is physical health, and then you have mental health, and they're separate. So you know, if you looked at this like industry, we've got to create a comprehensive model, because first of all, supply versus demand is such that the demand is so high in the supply in terms of professionals. So we've got to look at a model that includes the collaborative care model. The other part of it in answering the question is that we're pretty much a visual, you know, community, a society. We will see the athlete that's got a knee brace, and we recognize that, oh, they may have just had you know, surgery on that knee from a soccer injury or something like that. We cannot see, and the stigma from the neck up, we may not see that trauma or that anxiety, that depression that someone is living with. So it's that separation, and we have to make it more inclusive. I would tell you that Naomi Osaka did a great job for the mental health community by stepping up as a 23-year-old and saying that I am impacting this tournament. And so I'm gonna go ahead and withdraw from the French Open, because what I wanted was not to do the media because of my mental health. So what this young person did is going to make a difference. Now, industry has come forward and now supported her, but when she first did it, there was a lot of second guessing, and that's something where we need to be more receptive. But that goes to your question, and why? Because visual. And we need to move from that and say that it's what the World Health Organization said 20 years ago. There is no physical health without mental health. So we just have to find a way to absolutely make that a reality and reduce the stigma.
Paul, you had mentioned earlier when we were talking about racial equity, you had brought up issues around workforce development as well. So within the need to develop our current mental health workforce to meet the need and to engage in the collaborative care models that Dan had just referenced, What does the unified vision say we need to do in order to prepare for the growing demand we're going to see, to meet the current demand that we already have, and capture that cultural humility that was referenced earlier? That's a $1 million question, and there might be around 6 questions in one there, but you're a professional, so I'm going to let you go for it, Paul.
let's just start with the money for a second. And $1 million question. One of the things that we used to always do up till last year was apologize for the millions of dollars that we asked for of the federal government for mental health services, instead of demanding the billions of dollars that we needed. And the workforce question is really one of those billion-dollar questions. And I think we just need to recognize that we need more psychiatrists, we need more psychologists, we need more, licensed clinical social workers, we need more licensed mental health professionals, we need more certified peer specialists. We basically need more of everybody in this field. And in addition to that, we need more training for the non-mental health professionals who are clinical professionals, so that they can do a better job of recognizing mental health problems early on, and then helping to support and treat the whole person, and not just the parts of the person they happen to see, either as a general practitioner or as a specialist, say, specializing in cancer or heart disease or lung disease or diabetes, all of whom, people suffering from these conditions, all of whom have mental health needs also that are often going untreated. So you can see I'm kind of tacking on the billions of dollars here just at one level. But at the next level, I think what we recognize within the unified vision is it wouldn't be good enough, just to train all those people in, say, Vermont, a state in which I lived for a year and enjoyed immensely, because the people of Vermont don't look like the people of, say, Florida, another state I lived in. So it wouldn't be good enough to just be training all those Floridians, because they don't look anything like the people in Texas, another state I lived in. And frankly, none of those 3 states look like the people here in Connecticut, where I'm talking to you from today. The fact of the matter is, we need people of all cultures, we need people of all races, we need people of all backgrounds to become part of this improved and increased mental health workforce at the same time. And so we've got to do that by providing the academics training and support. We've got to do it by providing the scholarships and the grants for people who can't afford to be able to go to the graduate programs, the undergraduate programs they may need to go to from all communities. We've got to locate this training throughout the nation, in rural areas and in urban areas. And then we've got to make certain that all those insurers pay fairly for people who are providing mental health treatment services and supports, because I'm tired of paying my plumber, my carpenter, my electrician, and my auto mechanic, and even the people who take down the trees in my yard, far more than we're paying our mental health professionals to provide that treatment and support for us. So in a nutshell, I think that's kind of where we need to put our billions of dollars and effort and energy. And I think we tried to capture that as much as we could in the unified vision. And I think that would get us started. Won't get us all the way there, but it'll be a good start.
Great. And I want to follow up on something you just talked about here, and that I know is discussed quite a bit in the vision, which is about the role of peers in the workforce and how we can increase our capacity and increase our reach by the utilization of peers and or non-clinical individuals. So can you talk a little bit more about what that could look like in a community, and if people are interested in getting involved in that way, what they should do?
Well, people can work, peers can work in both clinical and non-clinical settings. And they do need training in order to do that, but the lived experience is the primary part of that training that people get. So with an additional 3,000 hours of experience and training, 40 to 80 hours of classroom training, people can really hone their skills, which are really the kinds of skills that serve us well in life and are transferable to other kinds of circumstances too, like other chronic conditions like cancer support and support for people with heart disease, peer support for those, and then work. And if they work, and if we train, I would say clinical professionals along with that to be able to use peers as part of clinical care teams, then we have proven, and I think we've seen all around the country, peers can work very effectively in clinical settings as partners, as part of a clinical care and clinical support team. But what I think we've also proved over the course of the last generation is outside of clinical settings, peers can do great jobs in social services settings, providing support to people as well. And so there are multiple job paths and multiple opportunities for certified peer specialists and trained peer specialists, even if they don't want to be certified by a state Medicaid program or certified nationally to work in clinical settings. There's plenty of opportunities, I think, for peers to work, and plenty of evidence that suggests that the services that peers provide are as valuable. I always remember one report saying, neither better nor worse in terms of their outcomes, but as valuable as the services provided by other mental health professionals.
Thank you. As honestly a non-clinical person who is living with a mental health disorder, I truly believe that we have a very big role to play in being able to help the workforce and to help our system grow to meet needs. So I'm just really happy to see that spelled out in the unified vision, because I believe that is an important and key component in order for us to move forward.
Yeah, Cheryl, building on that, we believe that we really should meet people where they are. And in meeting people where they are, that peer specialist is critically important. And as we talked about the 988 and crisis response, that's another pipeline, workforce development pipeline for that peer specialist, in terms of if we created a triage model where there's a mobile crisis unit in a community, just like there's in my community, there's 30 there's a substation with 30 patrol cars. Well, for every 5, what about if we had a mobile crisis unit and we had a triage team with a peer specialist, a social worker, and maybe the third would be law enforcement if they go out on a response together. And that peer has lived experience and can relate to the person, and can actually help with that engagement. So the peer specialist and growing that pipeline is critically important to our success going forward. And there's so many, as Paul said, there's so many different roles for the peer specialist. It's critically important.
Thanks, Dan. And I'm glad that you brought up 988 again. We did get a question from a participant, Patricia, who said that she's really excited to hear about the rollout of 988 and us moving towards full implementation in July of 2022. Can you talk about where we are in that process, and if it looks like we are on target for hitting that? Because just like Paul mentioned, basically funding for everything, funding for 988 is critical as well. So if you could give us an update on your thoughts about whether or not we're going to hit that goal.
User fees are critically important. The state legislatures have to pass legislation to actually provide the user fee. State of Washington looks close to getting that passed, and we're working with some other states. It's very slow to get that. Right now, if you look at your cell bill, your mobile phone bill, you'll see a user fee for 911. So what we need to do is to get a really good user fee for 988, and that's what is being worked on right now, so that we can operationalize it across the communities, because that's going to help building out that infrastructure. There's a few states that are on the front end, and we're looking to work with the new legislative sessions in the states for 2022 to see if we can actually get some more funding passed. So that's really where the opportunity is, and then there's the build out in terms of inside of the infrastructure that I spoke to. I would tell you that this is not going to be in 2022 and in July of 2022, you're not going to have something that's going to be pervasive across the country. This is the beginning of it. And it will take at least, I would say, 5 to 7 years at minimum to get us to a point where we have, just like 911, a pervasive number across the country, because there's so much of a build out that has to be done.
Great, thank you. I heard that we need to set our expectations around what the beginning of 911 was and how it took many years for that to roll out. So I appreciate you calling attention to that as well. I want to remind our participants that if you have a question for the panel, please feel free to drop it into the QA, and we will bring these questions up. And I'm going to start now. We actually got a really great question about the role of telehealth and how the future of telehealth could be used for reaching more people. We know that COVID really thrust us into having telehealth be the norm for the past 15 months, but heading into it, it was not. And it was quite the exception to be able to have services via telehealth. So Paul, I'd like to start with you. What are your thoughts about how telehealth could impact utilization of services?
The first is that I don't think that there's going to be any demand in the public to go backwards on the use of telehealth. Certainly, telehealth services, particularly in our area, have the opportunity to bring far more regular treatment and support to people in rural areas, to people in inner cities that have been underserved. It gives us far greater opportunity to match people culturally to providers who are culturally humble, are people from the same communities and with some of the same background experiences that other people are who are searching for people to treat them. And so I think all of those things are possible. I think the best indication of just how significant telehealth is going to be in our space is what we've seen in our mental health screening program, and who we've seen it in, which age groups are accessing our site to do mental health screening, and then to get follow-up resources through the internet, through the web. And when you see, in terms of the overall percentages, how many of those people are 11 to 17 and how many of those people are 18 to 24, again, 2/3 to 70% are in those age groups, and how it goes down in every age group all the way up to mine afterwards. I think we need to understand that if somebody my age group's trying to design what they think the telebehavioral health network or system's going to be 20 or 30 years from now, that they're going to be way out in outer space somewhere. And we really need to pay attention to how 11 to 30-year-olds are using services, because they're going to continue to access services this way. They're going to continue to expect a greater variety of services and service options that they can access this way. And so I think the immediate wave of the future, I'm just talking the next 5 to 10 years. I mean, we've probably gone 10 years forward in just the last year on telehealth side. I think the next 5 to 10 years is going to take us another 30 years beyond that. So bottom line is, I don't think I'd even want to try to predict how advanced and how incredible the telehealth, telebehavioral health services will be, service offerings just 5 years from now. But I think we can count on the fact that user demand is going to push people in that direction. And hopefully that's going to excite a whole new generation of people to become providers as well, because they're going to be able to provide services in ways that right now, sometimes, again, the older people in my age group are kind of resisting, the idea of, I got to figure out, they can't log on to the internet, much less figure out how to give people an experience, a private, experience that way. So the world is changing. I think it's changing dramatically, and I think very optimistic that I think this is going to be a leveling experience and a very helpful one for an entire generation of people who are going to be needing and wanting mental health services.
Cheryl, and very early on in the CEO huddle, as we were starting to meet in March of 2020 on Saturdays, the strength of the huddle also with telehealth was actually being able to message out and advocate for more funding and to say you need to reimburse for telehealth. So the voices of these CEOs was absolutely critical to helping increase the funding for telehealth. So that's another demonstration of the value of the strength of having this CEO huddle come together. And I see a path forward, as Paul has said, that we're not going back. And this appendage here is is the screen that is kind of connected to everyone's hand. It's almost, you don't even see a young person that doesn't have it in their hand. Almost only time you don't is when they're sleeping. So we've got to take advantage of that. With that said, we do have the bandwidth issues in certain communities that needs to be addressed, and we need to push for more access.
Actually, I'm really grateful, Dan. I feel like you read my mind with the last question that just came into the QA, because it was all about the infrastructure. If we are going to see telehealth expand, what do we need to be advocating for when it comes to increased infrastructure around internet, broadband, and so forth? And do you think that is a priority in the national budget conversation right now?
I think it is a priority. I don't know if it's a tier 1 or tier 2, but it's got to be a priority if you're talking about equity and access. So it is a part of what we all need to look at in terms of what we want to see advocated for. And if we're going to bring 988 full circle, we need to also bring broadband access full circle. So I don't think that you absolutely can do one without the other. So I think they're parallel tracks.
Great, thank you. And speaking of, there's infrastructure budgeting that is being discussed at the federal level. There's a lot of stimulus dollars that are coming out. One of the participants asked the question of all of this money that's coming out into the community, are we going to see any of it build not just the internet and broadband infrastructure, but are we going to see any of it build capacity within mental health? Or are we looking all at one-time funding that is going to disappear in a year?
Go ahead, Paul.
Okay. No, we're not just looking at one-time funding that's going to disappear in a year. There is a significant amount of one-time funding that came in, $8 to $10 billion that we all got for the mental health infrastructure, really. I'm going to say it broadly that way. And, that $130 billion for schools, if just, 10% of that were used for mental health services in schools, we could basically fund every child's mental health needs that we could identify at that point. But in the administration's plan, President Biden has put in permanent additional funding into the block grants, the mental health block grant in particular, and into programs. And this is not going away. I mean, the fact that we all came together, as we said, we stopped apologizing for asking for millions and started asking for billions. This is not going away. These billions are here. They're here to stay. And they're giving communities great opportunities to now think about how to invest based on the needs of the community. We still have a little bit of access or advocacy work to do to allow block grant monies, for example, to be used for early intervention and prevention services. And we're working on that together, and a number of us. And so, we've got some work to do on our end, but people should count on the fact that there are a lot more dollars coming in they have ever seen before. And finally, as Patrick said very early on in introducing this, finally, the silver lining in this pandemic cloud has been greater attention to mental health needs, and frankly, greater attention to upstream mental health needs, because so many people experienced significant anxiety and depression for the first time in this past year.
Yeah, I'll just build on that real quickly, just to say that, it's interesting that we've all, and we continue to use data to form our decisions. With that said, what came at us last year was unprecedented in terms of the pandemic, and it had us looking at two other emotional elements before we looked at the data: fear and pain. And the fear and pain of a parent looking at their young person who's in isolation, who's not in that social environment and not getting that education, and they're starting to see different things. That pain and fear have been able to drive the conversation from the standpoint of someone sitting and listening to the data and recognizing that I am a part of, or my family is a part of that data. So there's something here that pain and fear that came, and now with the data that actually forms all of this together. is really going to drive it for years to come in terms of funding. It's really our work now to look at how the funding should be distributed differently and how the funding should be used differently so we get better outcomes and we get better utilization across communities. That's the area that we need to work on.
Yeah, we're talking a lot about the federal budget and also local community input and investment into mental health. But you know, a big player that we're leaving out, and you touched on earlier, Paul, and we know is very significant to Patrick's way forward, is the role of the health insurance industry in revising rates and making sure that people are being paid for the professional services that are delivered. What a question that came up from a participant is, what can community members do in order to demand that health insurers pay for their part in the system? And
well,
with you, Paul, since you brought it up earlier.
Yeah. Okay. So you know, insurance is just a product that people are buying, and you know, consumers of products can demand that those products meet their needs. And I think that one of the things that we've often not done enough of is insist that the coverage that our employers provide, or the coverage we provide as employers, is fair coverage and covers the things that we need it to cover. And I think the other thing that we can do is that we can do at one level, but I think at the policy level too, we have to go to state governments. We have to go to state legislators and others and demand that the insurance regulations they put in place that are supposed to help level the playing field, you know, between individuals and the businesses often frequently who insure, you know, provide the insurance, and the insurance companies who are providing it, that there is a level playing field there, and that people are getting, you know, what they expect. You know, I can do good guy, bad guy thing with insurance companies. I mean, you know, and frankly, they, you know, I'm like everybody else. I mean, at various times, particularly my son's treatment when he was alive and a kid, for trying to get him care and service, and the insurance company, you know, keep turning me down, and then I'd have to appeal it and all that. So I can go there with insurance companies, but I can also say they've got a valuable role to play, and we've got to figure out how to be able to work with them in this system, because the only one we got right now, and if we're going to make certain that we get the kinds of services and supports that we need, we're going to have to be able to work with our health insurance companies, our business partners, and our elected officials, and make certain that we have as level a playing field as we can, and just basic human needs, which include basic human mental health needs, are covered, and covered fairly.
We're starting to run out of time here, so I want to thank the participants, because there are so many questions here, so many wonderful questions that we haven't been able to get to. And while I would love to keep you guys for another hour, I know that you're very, very busy, and I want to respect your time. So before we wrap up today, I would like each of you to tell me, what is the one thing, the one most important thing that our viewers can do to help advance the unified vision and improve mental health and substance use systems? I'll start with you, Paul.
The most important thing people could do is work together. One of the things that we all demonstrated in the unified vision was that organizations, advocacy organizations, that many of which historically in the past had not worked together, could come together and develop this kind of unified vision that would help show us a way forward that would meet everybody's needs. And still, I think sometimes people, you know, get caught into being pitted, you know, one against another, who are just advocating, parents against children, you know, caregivers against people receiving care. It's just, you know, liberals against conservatives, you know, whatever the way it is that people can be divided. There are people out there who are trying to divide us, and there are people out there who are really just, you know, trying to promote themselves or their own way of doing things and not working together. And so I think all of us, you know, Patrick, and you talked about the importance of what you do in Illinois. You know, Dan, you know, commended the NAMI affiliates in Illinois. I would do the same with the Mental Health America affiliates in Illinois. And the biggest commendation goes to the fact that so many of our affiliates are all working together these days. And when they're all working together, that's when states start doing things differently, just as when we're all working together at the national level. That's what got us the billions. You know, that is the one thing that got us the billions. And it's the one thing that got us reform legislation in 2016. It's just working together. And so that's over and over again. My one thing is just work together.
That's a really great thing. So thank you. Dan?
Building on what Paul just said, cross-sector collaboration. I think what kept this CEO huddle together Saturday after Saturday was that we're all in the same mission of changing lives, of improving lives, and that was the common denominator versus our different constituencies. And we need to keep that in mind out in the communities and in the MHAs and the NAMIs, and making sure that we're, there's strength in numbers and working together. And 988 is a tangible, tactical piece, workforce development and telling young people about peer specialists and going into this sector, making it an opportunity for them, I think is critically important. And I would just leave it with, something that I've said many times and shared it with the huddle. People don't care how much you know until they know how much you care. And I think that that's really the part that is going to get us there, is demonstrating how much we care and then putting that to work.
That's fantastic. I want to thank you so much. I am so thankful I was able to unmute myself finally in the beginning of the session so that we could have this great conversation today. And I'm just incredibly lucky to be surrounded by such great thought leaders, including yourself and Patrick. So thank you so much.
Thank you.
If you enjoyed what you heard here today, I ask that you please make a donation to the Kennedy Forum by clicking the donate button in the top right hand of your screen. Your support allows us to bring these conversations to you, and we will continue to do so. I want to thank everyone today for their participation, and I really appreciate the final thoughts of us working together and showing that we care, because it's only when we care that people will listen to what we say. So very, very important resources to take away. I encourage you to read the Unified Vision. You can access it through the chat box. We also put the links to Mental Health America and NAMI, so please visit their websites as well. The Kennedy Forum sees you as a partner for moving this vision forward. Throughout 2021 and beyond, we will continue to provide educational opportunities and opportunities for you to engage in these dialogues. So watch your email boxes for more information. Thank you for your participation today and for your commitment to mental health.